recorded for the future. For those of you who are joining right now, make sure that you are muted and you have your cameras off. We will be sharing slides and the speakers will be coming on screen as soon as we call them in. Welcome again to the 5th Latinx Health Conference, a community-centered approach to address childhood obesity. Please join us to welcome Dr. Rachel Thornton, Associate Director for Policy at the Johns Hopkins Center for Health Equity, and Dr. Sarah Polk, Medical Director of the Children's Medical Practice and Co-Director of Centro SOL.
Thank you, Monica. Thank you everyone very much for joining us today at our 5th Annual Centro SOL Health Conference. As Monica mentioned, the topic today is a community-centered approach to childhood obesity. Obesity is a pernicious problem. I'm sure many of you are very aware of all the details of that. It has become a particular focus of Centro SOL due to the disproportionate impact it has on the Latino community, both because of its impacts in childhood and on into adulthood in the form of cardiovascular disease. And as we saw prior to COVID, and as the COVID pandemic has revealed, obesity really capitalizes on existing vulnerabilities, specifically low income and issues related to neighborhood safety. But obesity does not respect boundaries of race or ethnicity. And in part, that motivates the conversation today and the uniting theme of community. So we will discuss some community-centered approaches. And in order to have success in reducing both the childhood obesity epidemic and its impacts, we are going to need a community of partners in order to make progress. And those partners are going to include people across sectors. You'll hear from people working beyond healthcare today, but whose work is very relevant to this problem, and also require the partnership of people working with a wide variety of target populations, because this problem is having an impact across populations. So we're especially grateful today to co-host this conference with both the Center for Health Equity at Johns Hopkins as well as the Urban Health Institute. We, in many ways, share a mission, but have a history of focusing on particular populations. And I would be remiss not to just review the Centro SOL mission policy, which is to promote health and opportunity for Latinos by advancing clinical care, research, education, and advocacy in partnership with our Latino neighbors. And I will now turn over to Dr. Rachel Thornton, for whose partnership I am quite grateful.
Well, thank you so much, Dr. Polk. It really is exciting, I think, that that Centro SOL has had the vision and the foresight preceding the COVID pandemic to use this conference as an opportunity to unite communities and to recognize that the Latino community in Baltimore shares many challenges with communities that have been here for centuries that still remain marginalized, in particular many of our African American communities. And as well faces unique challenges of their own. And so I think this is really a call to unite and for us to learn from one another. And the Center for Health Equity is really committed to envisioning and realizing a community, a nation, and a world in which every person can achieve their best health. And that is the quintessential definition of equity, not equality, not everyone getting the same, but everyone getting what is needed for them to achieve optimal health. So we're thrilled to be co-sponsoring this, and also as Associate Director of the Urban Health Institute. The Urban Health Institute is also thrilled to be co-sponsoring. And again, I think this is really in line with many of the goals of UHI to foster conversation and exchange, and to work in partnership with communities in Baltimore for the betterment and improvement of health and social justice in Baltimore City. So, I think this is just thrilling and exciting. And just a few housekeeping notes before I turn the mic back to Dr. Polk. As Ms. Guerrero-Vasquez already mentioned, the conference is being recorded. We are also really excited to have Lauren Green from Dancing with Markers, who is going to be doing live digital scribing of our event today. This is an exciting way of communicating and synthesizing the conversations and the dialogue that occurs. It's a visual note-taking that's done with an iPad to produce a high-level summary to help solidify the key takeaways from the conference. At any point, you can pin her and watch her do her work, to watch her drawing and live in the moment, conveying the conversation through art and graphics. So, and also we just want to put in a plug not to miss the closing session with special guests, community members who will share their experience and research. So without further ado, I will turn things back over to Dr. Polk to move us forward in the program. And just, sorry, one last programming note for everyone. The program is available to you, including links to the panels that you are assigned. You should have received those, but if you need a reminder, you can also access them on the Centro SOL website, www.jhcentrosol.org.
Thank you, Rachel. I just want to offer a very important thanks. Today is possible thanks to our the partnership between these three centers, Centro SOL, the Urban Health Institute, and the Johns Hopkins Center for Health Equity. But really a very particular thanks to Monica Guerrero-Vasquez and Nancy Malello, who have made this possible. You've met Nancy, I'm sorry, you've met Monica. Nancy is with the Center for Health Equity. So thank you very much to them for making this actually possible. I would now like to introduce our keynote speaker, Dr. Eliana Perrin. I think it's more interesting to hear her talk than to review all of her accomplishments. There are many of those. There's more information on our website. But I will point out that she she has a lot of responsibilities within her job, and they're all very relevant to what we're talking about today. So she was on the faculty at UNC, but has more recently been, is now at Duke University, where she's a professor of pediatrics, division chief of primary care pediatrics, the director of the Duke Center for Childhood Obesity Research, and the program director for the National Clinician Scholars Program at Duke. So she is having an influence on people who will need to address this problem in myriad ways. It's great to have her here today. And also, just on a somewhat lighter note, it's fun to have her here because of a shared mentorship by Tina Chang. Tina Chang is the departing chair of pediatrics at Hopkins. Dr. Chang was really instrumental in getting Centro SOL off the ground, and we will very much miss her. And she was also an early career mentor of Dr. Perrin. So it's fun to bring things together. So thank you very much, Dr. Perrin, for taking the time today, and I look forward to hearing your presentation.
Thank you so much. Thanks for that kind introduction. And you are absolutely right that Tina Chang has had a profound influence on my career, and I was actually her first research coordinator. So I'm going to share my screen and hopefully you can all see that now.
Yes.
Yes.
Yeah, okay, great, wonderful. Yeah. Wonderful. All right, so thank you again for the introduction. I'm delighted to be here this morning presenting the keynote, truly honored and humbled. I'm going to be talking about One Healthcare-Based Interventions Plight to Prevent Childhood Obesity in Diverse Populations. And I'm going to be sharing both some successes as well as some challenges. Our roadmap for today, we're going to talk about the importance of primary prevention of obesity. I'm a big believer in prevention of obesity, and I think it's particularly important to do this in communities at highest risk. I'm going to share some thoughts about our green light study. I'm fond of saying I have, in some ways, 3 children. I have my oldest son, Jonah, who's 20. I have Daniel, who is 15, and then I have green light. It has been a life's passion of mine, and it is a study which aimed to prevent obesity. I'm going to share a little bit about that and what it's taught us. And then I'm going to share some challenges with respect to studying and serving the Hispanic and Latinx community. And from now on, I'm going to try to just say Latinx in deference to the conference title, but I realize that these different terms are important, and so I just wanted to share the shortcut. And we're going to talk about some potentially surprising findings and some future directions. So, as was mentioned in the introduction, childhood obesity is very prevalent, and prevention is super important. So more than 20% of preschoolers are overweight or obese. And preschoolers who are overweight are more likely to become adolescents who are overweight, who are actually more likely to be adults who are overweight. So this problem starts very early, and prevention is really critical. Weight gain in the first months of life even is associated with increased cardiovascular risk in early adulthood. So you almost can't start too early here. And that is a key takeaway point. As was mentioned, this is an epidemic that disproportionately strikes communities of color. Non-Hispanic Black, shown here in the bluish purple, and Latinx children are disproportionately affected by obesity. The Latinx are portrayed in the light green and are often the highest bars, certainly for total and for boys. But this is also an epidemic of poverty, and children in families with low incomes are disproportionately affected by obesity. These 2 graphs, one for females, one for males, shows the difference between the lowest dotted line, where families are at greater than 350% of the federal poverty level, compared with those in the solid line that are less than 130% of the federal poverty level. And you can see that this actually disproportionately strikes females more than males, but it is an impressive trend across the years that it was studied. And these are the families we'd love to see. Moms breastfeeding their infants, engaging in tummy time with their infants. These are just really beautiful scenes. And for me as a pediatrician, I always love showing pictures of cute babies and beautiful families. But unfortunately, this is the scene we too often see. This is actually from the side of a local Latinx store in Chapel Hill. And you can see the babies are literally swimming in a sea of what Kelly Brownell termed the toxic food environment. In this case, sort of calorie-dense, nutrient-poor foods such as chips and sugar-sweetened beverages. And this was a real ad, folks, from McDonald's. For those of you who can't see it, it says, "Where will she have her first French fry?" And it portrays an infant finger wrapped around an adult finger, potentially thinking about her future French fry. And I hate to say it, but a lot of families that I see share that their 6-month-old's favorite food is French fries. Tasty, soft, prevalent. And advertisements like these show the challenge that office-based prevention is up against. And communities of color are most at risk for that toxic food environment, which pervades for us all. But for predominantly Black and Latinx neighborhoods, they have less access to supermarkets. Fast food restaurants are more prevalent in their neighborhoods and in their school districts. Food and beverage marketing directed at Latinx consumers is more likely to promote calorie-dense, nutrient-poor food and drinks, such as what we saw on the side of that storefront. Brands and fast food, candy, sugary drinks, and savory and sweet snacks have more targeted advertising on Spanish language TV. Brands promoting water, nuts, and fruit, some of the healthier foods, were unlikely to target Latinx consumers. And fast food accounts for a larger proportion of food advertising on Spanish language children's TV rather than English language TV. If you don't think this is targeted, you're really wrong. This is very clearly targeted. And products like these, and again, this was a real campaign, like the McDonald's ad, these products no longer exist. But I think these show the link between unhealthy sugar-sweetened beverages and young children, a link that the companies that promote them have been trying to make for quite a long time. And you can see the hard time that families are up against in fighting the toxic food environment. And again, like with fast food, sugar-sweetened beverages are more commonly promoted in communities of color. They both consume more sugary drinks and juice, and companies target advertisement for sugary drinks at Black and Latinx consumers, preschoolers watching Spanish language TV. And then there was a study for Texas high schools finding that outdoor food and beverage ads were more common around schools that had higher numbers of Latinx students. So again, a very targeted approach here. And this just sort of brings to light the importance of this statement. Paul Wise was a pediatrician, so he comments about pediatricians. The same can be true for really any health professional that spends a lot of time with children. But here he says, pediatricians are the ultimate witnesses to failed social policy. And I want to be very clear that the kinds of things I'm going to be talking about today are the kinds of things we try to fiddle with in healthcare. And I do think we can make an impact, but don't think for a minute that I don't think that systemic racism and bias are at the roots of a lot of the problems we're seeing. Nevertheless, I do think healthcare can play a role. And I think so ever since I heard this quote from some really early research I did early in my career from a parent who said, "I wish we'd never started the juice habit. No doctor ever told me not to give him juice. Now he's hooked, but it would have been easier not to start in the first place." And that idea that many childhood risk factors for obesity are potentially modifiable is what has given birth, no pun intended, to a range of research that colleagues and I have done ever since. So things like formula feeding instead of breastfeeding, introduction of solid foods before 4 months of age, consumption of sugar-sweetened beverages and juice like we discussed, screen time. There probably is no greater behavior that is more linked in rigorous research to obesity than screen time. Excess portion size and inadequate physical activity. These are potentially modifiable. These are places where maybe we in pediatric care can make a difference. And I will be the first to admit our research in the area of early childhood obesity prevention is not as robust as it should be. So while I share some references that guided us early on in our work, and there are many since then as well, I'll be the first to admit that we actually need even better research, sort of looking at relationships between early behaviors and later childhood obesity risk. But I'm still a big believer in primary prevention. And I think I shared that my oldest son is 20. That is a much younger version of me and a much younger version of him. I think it was day of life 2, actually, when we were sent home from the hospital. And for those of you who work with young children, this is really the promise that we can keep them safe and healthy. And we can do this. We can help parents from the start. And I'm reminded of this each and every time I have the good fortune to be in clinic. And this was a mom who gave us permission and with a lot of pride to share this picture of her beautiful son. And like so many parents, she comes to us asking wonderful questions and hoping for some answers. And I think with partnership, we can provide those. And we can provide them really well, I think, with some great interventions that so many have thought about. The study that's near and dear to my heart, as I shared, is the Green Light study. And the goals of that study were to provide low literacy educational materials for parents, to address cultural differences and language barriers, foster the things that we know are important about health communication, teach back, goal setting, motivational interviewing, and to provide all of this training to residents, our future doctors, and to prevent obesity at age 2. That's the ultimate goal of this study, by starting with babies at 2 months of age. It was considered very novel at the time to start so early. We'll talk about some of the pitfalls of that. So the Green Light study was born. It was funded by an NIH R01. It was a cluster randomized trial of a literacy-sensitive obesity prevention intervention versus an active control. Basically, we had 2 arms of a study. One that was in half the people trying to prevent obesity, the other in the other half of the study that was trying to prevent injury prevention. And we did this in 4 academic primary care resident clinics. And we had over 850 English and Spanish speaking families with children enrolled at 2 months of age. And we followed them through early childhood. With our first grant, we followed them through 2 years of life with the goal of preventing obesity at age 2. Then we got a second grant, a competitive renewal, to follow those same kids until their kindergarten visit. And then I'll be sharing later in the talk a little bit about a study we're doing right now. So again, this was an intervention versus an active control. And in both cases, we were training the residents, our future doctors. In the case of Green Light, we were training them in effective health communication and giving them these toolkits that I'll explain a little bit more about, but basically brochures that they could use with families at all the well child visits. And I do want to share with you just how many well child visits there are for those of you who don't have kids or are not pediatricians or family practitioners. So we see children early on, including the 2-month, 4-month, 6-month, 9-month, 12-month, 15 and or 18 months. Different practices do it differently, and 24 months. That's a lot of touch points in the first 2 years of life. On the active control side, we trained residents in injury prevention, and we use something called the American Academy of Pediatrics, the Injury Prevention Program, a little bit of a boring name, using those at well child visits, again, at the same health preventive services visit schedule. And we created these booklets. Basically, the idea was families would receive 1 or 2 booklets at well child visits, 1 core booklet that was staged for their age, and then 1 supplemental booklet, say on breastfeeding or on family activities. And the booklets were short, and at the end, they included some goal setting, and they were designed to be used interactively during the visit, and they were available in English and Spanish. We actually now have all of our booklets available also in Chinese through a project done in New York City's Chinatown, thanks to one of our principal investigators, Shauna Yin. But for this study, it was just English and Spanish-speaking families. You're not meant to read all of this, but suffice it to say, using the best evidence of the time, again, over a decade ago, we tried to think through what are the core topics and takeaways for parents at each of the time points, and therefore, what kinds of messaging do we want to provide to parents? And we provided what we thought was very culturally appropriate materials. featuring foods like mangoes and rice and beans and some other foods that you might not see in typical American Academy of Pediatrics brochures. And then we also provided some tangible tools to families who were part of our study, including this onesie that said, "I'm sweet enough, please no juice." And for those of you who are questioning the translation, who are bilingual, we'll come back to that soon. We also had a beautiful resident curriculum for families. It didn't look quite so spiffy. This is the front slide for our curriculum that we're using now, but it was the same idea back then, that we were really teaching residents both how to prevent obesity as well as great ways of engaging families in partnership around physical activity and diet and feeding. So I love the Green Light Study. I think I shared that. And one of the reasons I love it is you can look at our overall population of 860 children. This is in the first column. We included children who, especially at that point in time, were rarely being included in studies. You can see that 49% of our overall study had a parent who was not born in the US. 50% identified as Latinx. 35% had the preferred language of Spanish, and 26% did not graduate from high school. But I actually think what I'm about to share was the most striking aspect of the study and was really eye-opening to all of us on the study team. 60% of families had an annual household income of less than $20,000. That is extremely low, and that was a household income. So no matter how many adults were living in that household, that was the household income. Now, when you look at just the Hispanic or Latinx means, much higher percent are non-US born, 83%, 70% had the preferred language of Spanish, 41% had less than a high school education, and here now you have close to 70% with an annual household income that is strikingly low. And as much as I love the Green Light Study, and I really do, I think we started our intervention too late. And unfortunately, we discovered this relatively early on when we wrote one of our first baseline papers. I lead authored that paper on sort of obesogenic behaviors at 2 months. This was baseline. This was when we were starting the study, but unfortunately, even at baseline, 45% of our families were exclusively formula feeding, only 19% were exclusively breastfeeding, 12% were already introduced to solids, and 43% were put to bed with a bottle, meaning that their children weren't able to set their own satiety. And when we looked at TB, the results were maybe even more striking. We actually asked this question 2 different ways. How often is the TV on in the room that the child's in? And that's actually the second bullet, sorry to misorder that, but 90% of babies were exposed to TV for a mean time of 6 hours a day. Now, granted, this is a conglomeration of families that do have the TV on a lot when the baby's up and awake, and families that are living in one-room dwellings. So if the baby's in that room and the TV's on, you know, that's just the state of affairs. And then there are a lot of families who leave the TV on 24/7. But I think that the first bullet is actually even more striking, where 50% what we called actively watch TV for a mean time of 25 minutes a day. And so that means that parents are putting their infants in front of the TV in order to watch TV. These are 2-month-olds. And 44% of parents watch TV at least half of the time they were feeding their infant. Again, what this means is they were probably less likely to be responsive to those important feeding cues the babies were offering them. There were some racial ethnic differences in these patterns. I want to point out that no group was immune to what we would call obesogenic behaviors by a long stretch, but compared to white parents, Black parents were more likely to put children to bed with a bottle and to bottle prop and to report more TV watching. Hispanic, Latinx parents were more likely than white parents to encourage children to finish feeding, to bottle prop, and to report less tummy time. And white and Black parents were more likely to report television watching than were Latinx parents. And the other unfortunate thing about Greenlight, other than probably not starting early enough, and these two things may be related, is that overall it was actually a negative study. We were unable to prevent obesity at age 2. The intervention kids did have lower BMI scores, basically their weight for length and age, compared to those in our control group at 3 major time points, at 6 months, at 12 months, and at 18 months. But by age 2, this had all evened out. And that is problematic because that is the time point that we chose to be the main result of our study. One of our takeaways is the fact that this intervention was offered in well child primary care. And I told you how often that schedule was: 2, 4, 6, 9, 12, 15, 18 months. But then again, there's no visit between 18 months and 24 months. So if you're talking about an intervention that's provided in the doctor's office and you have a 6-month gap between your latest dose and the time of the intervention, you might have been shooting yourself in the foot, and we might have been doing that. But we have to be honest and say that there was no difference in the percent of children who were overweight at age 2. This was a negative trial. That does not mean that we did not learn a tremendous amount of important lessons. Many publications, many abstracts. More importantly than the numbers of publications or abstracts is the fact that the people doing work on Greenlight were trainees of all of us. And this has been a wonderful platform for people to learn about obesity, to kind of ask questions from our now very replete and robust data set, looking at questions from bottle size by Charles Wood, who was a postdoc at the time, who found that when bottle size was larger than necessary, infants gained weight more quickly. So we should start babies with appropriate size bottles. Callie Brown, also a postdoc at the time. Now Charles Wood, by the way, is on faculty with me at Duke, and Callie Brown is on faculty at Wake Forest. But she found that babies gain weight too fast when their parents think they're too skinny. And she controlled for a lot of factors and found that weight perception still emerged incredibly important. So we should be actively counseling about weight perception. No, your baby is not underweight, despite what you may be worried about. Michelle White, who was a postdoc at the time and is now on faculty with me at Duke, looked at some environmental contexts that we could take a peek at with Greenlight, and found that neighborhood commute time was associated with health behaviors and food access, emphasizing the importance of contextual factors when designing health interventions. Charles Wood, again, looked at complementary feeding associated with slower weight gain if we delay that. Again, so really trying to encourage families not to put rice cereal in the bottle and delaying solids until preferably 6 months of age. Alex Hish was a medical student who worked with us, who has a paper hopefully forthcoming, looking at active screen time and finding that not only was it common early on, as I shared in that original paper, but if families were engaged in early screen time, they were the ones who were more likely to be engaged at age 2. So it really is important to start this habit when to stop this habit when it starts. Erin Pankowitz was a resident with us and found the same thing for early juice and sugar sweetened beverages, that earlier consumption predicted later consumption. So many important results, but also challenges. So I talked about the fact that we had culturally adapted materials, and we really tried, but whose culture? Our original study took place at 4 sites, and you will see the country of origin of those parents differs depending on the site. So we talk a lot about the fact that the Hispanic and Latinx community is not a homogeneous community. And when you are doing a national study that takes place at individual sites, and you are trying to be culturally adaptive, that is very challenging. You can see some of the numbers here. of where our families came from, and see even that the first, second, and third country of origin differed quite a bit, even though Mexico predominated across most, but not all, of the sites. And I live in the Chapel Hill, Durham area. Durham is a new site for Greenlight's new PCOR-funded project that I'll be sharing a few comments about. And as of 2019, Hispanic and Latinos make up nearly 14% of Durham County's population, whereas North Carolina's population is only 9%. But I want to point out something really interesting, that if you just take the microcosm of North Carolina, obviously a microcosm for the entire country, the statistics don't match up with the statistics nationally. The Latinx population in North Carolina is younger, more likely to be recent immigrants, more likely to not have a high school or high school diploma or GED, and more likely to have children who live in poverty. So you cannot take one state, one county, and do any kind of extrapolation of the population. It is a very heterogeneous population, and we have only served to homogenize it with studies like this. And speaking to that point, we are so proud of the fact that all of our materials were translated. That cost lots of money in the study, it cost lots of time, it was complicated, but it was incredibly important. And again, as proud as we are for having done that, we do wonder whose Spanish are we talking about? And actually for this part of the talk, I'd really like to turn it over for this slide to my research coordinator, Carla Mena. Monica, if you could please open up her microphone so that she can share in her voice, because many of these were her insights.
She is in.
Thank
Great.
you so much, Dr. Perrin, and thank you all for being here today. I will briefly say that, as you all can see, these are some of the words that as a study we have been working with and we have been including on our intervention. And for each one of these words, there were at least 3 different meanings that were being brought up. And we had to kind of have the conversation. There were most of the clinical coordinators are actually bilingual, and Dr. Perrin will talk about the PI structure. And at the end of the day, we were making decisions based on literacy levels, but also on kind of everyone's input and making sure that one word would hopefully, work for everyone. One of the biggest, I think, controversial words was breastfeeding. Amamantar is used mostly in all of our sites and all of our clinics. And we ended up going with dar el pecho, which was not necessarily something that everyone agreed on, but we ended up having to compromise, right? And then even to say like, great work, or right back, or hang in there. And for those of you who are bilingual, you know that sometimes, a lot of times we'll say like, right back, and someone will be like, échame la llamada, o te llamo para atrás, which again is not something that is Spanish that has been adapted. It tends to be Spanglish. So we have come up with these words. There are other words that we continue to work on, but we wanted to bring a little bit of what we went through, what we continue to go through, and hopefully we'll continue to improve. Thank you, Dr. Perrin.
Thank you so much, Carla. And I am so fortunate, as you can see, to work with a team that is so thoughtful and insightful about all of this. And I want to share that the countries of origin was something from some work that Sophie Ravenbach, who was one of my other research coordinators, had looked into and really brought to light the differences of the communities we were working with. So nonetheless, even though there's been some challenges, there's also been some important lessons that we have learned through inclusion and query. So Dr. Corey Flower, who's one of our PIs, led this work looking at satisfaction with communication in primary care for Spanish-speaking and English-speaking parents. Basically, we gave something called the communication assessment tool after each and every visit to parents. So having nothing to do with obesity or injury prevention or any of our key metrics, we also looked at communication in this study. And what we found was that compared with English-speaking Latino and non-Latino parents, fewer Spanish-speaking parents reported satisfaction across 14 communication items in the CAT. After all adjustments, Spanish-speaking Latinos were still less likely to report high satisfaction. These are important things, and especially important to obesity prevention and the partnership that is necessary. The way the physician greeted them, treated them with respect, was interested in their ideas, gave as much information as they wanted, discussed next steps, and spent the right amount of time with them. These are really, really important domains, and our Spanish-speaking Latino parents, whether or not an interpreter was used versus a Spanish-speaking provider, they reported less satisfaction. And that was actually surprising to some of us. It may not be surprising to all of you. It was surprising to us. You know, I think the common stereotype is that this is a population who's really happy and satisfied with their care and quote unquote compliant. And I think when we use words like these without actually asking, we do ourselves a disservice. Another important and surprising lesson that we learned, this work was led by Charles Wood, looking at beliefs regarding infant weight and future health, and found that this too differs by race, ethnicity, education, and income. I'm going to concentrate right now on the Latinx findings, but basically he examined characteristics related to two statements that we had early on in the green light study at 2 months of age. I'm worried that if my infant weighs too much, he or she will not be healthy. And we actually thought very few people would say that they would think their child was not healthy. This is the one we thought would be very common. I'm worried that if my infant weighs too little, he or she will not be healthy. And then we dichotomized responses to agree versus disagree. And we found some really surprising findings. So Hispanic families, as opposed to white families, much more commonly agreed with that statement that weighing too much affects health. And this was counter to stereotypes. So were the findings of this entire study. So 62% of parents believed that their infant would not be healthy if they weighed too much. This is across the board. More, granted, believed that their infant would not be healthy if they weighed too little, but not that many more. And Hispanic or Latinx parents had over 3 times the odds of believing that an infant weighing too much would not be healthy. Again, preconceived notions of cultural beliefs may not be true. That is the understatement of a generation. But these were 2 studies done in the green light study that came out of inclusion and query. Still so much more to do. And our group has been delighted to have the opportunity for a do-over. And a do-over we have done. So we got together and we thought, what have we done that's done well? What have we done that's been done poorly? And one of the things that we thought was done poorly is that we started too late. So, and yet we're all primary care pediatricians, and without partnering with obstetricians, we are doing the best that we can, and starting with newborns, boosting messages and content areas identified in our original study as most important to weight gain: portion size, weight perception, complementary feeding. And then we've updated now the toolkits according to new American Academy of Pediatrics guidelines and a decade's worth of research telling us what's really important in obesity prevention. This launched the Greenlight, we call it 2.0 toolkit, and our PCOR study. The study idea here, and this is a study in progress, is to compare that new and improved set of materials which we're providing to all families. Compare that to half the families will be getting an augmented additional mobile and web platform support using the platform of the Duke Digital Health Center, the IOTA program, and that work is led by Gary Bennett, Dory Steinberg, and Melissa Kay. The hypothesis is that more frequent, tailored, and asynchronous support, asynchronous from the doctor's office visit, not asynchronous with their lives, through digital health will augment green light well-child visit behavior change towards early childhood prevention. So this is just a little table that sort of summarizes the differences. We're now starting with newborns instead of at 2 months. We have new and improved booklets. I'll show you some of the graphics. We have 6 sites instead of just 4. We are PCOR funded now instead of NIH funded, and we're randomized at the individual level. We still have an ambitious recruitment target of 900, but it's actually less per site. And instead of just getting stakeholder advice at the beginning of the project, we now have an advisory board, as is the PCOR way, that incorporates the voices of patients and providers and other interpreters and lactation consultants and other key stakeholders throughout the intervention. We have a cool new graphics program, but still the same set of booklets and some supplemental booklets, now one on sleep, which is really important to obesity prevention. Again, a beautiful sort of layout, and this is like one of the early pages that shows what the green light symbolism means throughout, green and yellow and red. Everything starts with some 3 key messages and always an adorable picture of a baby. And now we actually have all families can link to, all families in the digital intervention can link to a web platform that gives them both information about their own child and where they fall on the weight curve, as well as some tips about keeping your 9-month-old growing healthy, or whatever age the child is, of course. We also have text messages going out to all families in this arm of the intervention. This has been a long process to design all of these messages, to be able to ask families what their goals are, to prompt them about how they're doing with individual goals, and then also to kind of keep them with their goal setting and give them feedback all along the way. The families actually think there's an individual person texting them back. It's actually all automated, but they feel individually supported, which is great. And so I can't tell you any results of this study. We've enrolled 300 participants of our 900, so getting there. Obviously, COVID has altered some recruitment strategies here. I want to summarize with things that I think our studies have done well and things that I think our Greenlight studies have actually done poorly with respect to the Latinx community. In terms of well, I think that fundamental decision we had early on of including Latinx participants, regardless of ability to speak English, has served us and the community very well. Always having bilingual research coordinators. You see just in this presentation alone how much insight they can lend, like Sophie Ravenbach's work on country of origin and Carla Mena's work that you heard her talking about some of the language translations and the importance of that. There are a couple of us who are bilingual, and that has helped, but honestly, the research coordinators have been tremendously helpful here. We did include focus groups and some participant reactions for Greenlight 1.0 to design our materials. Now, of course, we have an advisory board that has multiple perspectives. We also, with our new PCOR study, have a new diversity, inclusion, and equity committee within our broad study team, and that's a group that looks at everything from recruitment to compensation to materials, and really looks at issues of diversity, equity, and inclusion. And we have worked really hard throughout Greenlight. It has not always been easy to advocate for ways to reimburse participants without collecting Social Security numbers, given that in so many of our communities, families are appropriately concerned about ICE roundups, et cetera, and are very, very concerned about either giving out Social Security numbers or not having them and being caught that way. So super unfortunate, but we want our great work and our great trust with the community to continue. What have we done poorly? Well, I admitted at the beginning that although we do have a lot of frequent touch points with parents in the first 2 years of life, just locating this study within a clinic rather than the community is probably not the best. It's probably okay for something like this, but I do think the majority of our studies should be leaning more towards working in and with the community a little bit more than just inviting them to our clinics for well child care and to advisory stakeholder groups. We have no Hispanic or Latinx PIs, so none of us leading the study have that lived perspective. You heard from Carla beautifully how the one size fits all with respect to specific language translation and cultural adaptation is not ideal. For our PCOR stakeholder group, again, we have this wonderful advisory board, but that takes place in English. So I think that doesn't lend a voice to those who cannot speak English. And we have, and this is important, fundamentally focused on individual behaviors. Again, at the request of the community and parents who told us they really wanted doctors to be advising them on some of these things. But still, I, as a researcher, feel that focusing on individual behavior change at some level neglects what is overarching systemic bias and the need for structural and policy change. So this is a Hopkins featured perspective that just came out, what we can learn from COVID-19 and the undocumented Latinx community. And obviously COVID-19 has had tragic consequences throughout our nation, but has fallen particularly hard on our Latino community. And this has given us some future directions, and for all of us who do research in any areas, anything like this, this is the important research pivot of our times, right? COVID, if anything, has elevated the importance of preventing obesity, even while the behavioral landscape is changing rapidly. So think about what Greenlight is promoting. Greenlight is promoting physical activity. Gosh, isn't that hard these days? Greenlight is promoting good sleep. Who's getting a good night's sleep these days? Greenlight is promoting no screen time. Again, I think all of us, our screen time has gone up. Also, COVID has really brought to light issues of fundamental equity and who is getting hurt by this epidemic more than others, and the incredible importance of mitigating the effects of poverty because poverty is increasing, and again, it's disproportionate as a result of COVID. And so we are extremely fortunate to have gotten a supplemental, one of the first supplements, I think, from PCOR to focus on vulnerable families. They gave us about $500,000, which is incredibly generous, to enhance our study. And the goal of the study enhancement is to do both qualitative and quantitative work around these issues. Qualitatively, we're going to be looking at the impact of the pandemic on social, emotional, financial, psychological, and healthcare needs, having nothing to do with obesity. The quantitative part does have to do with obesity. We're looking at the result of the pandemic on weight-related behaviors and infant growth in this multi-site sample of low-income and minority families. We're kind of perfectly positioned because we are in different parts of the country. We have vulnerable families enrolled, and we had them enrolled well before the pandemic, during the height of the pandemic, and praying for after the pandemic. Doesn't it sound nice to say that, those words? But it really allows us to look at different geographic locations and this sort of tragic natural experiment we're all engaged in. So happy National Hispanic Heritage Month, everybody. this work would not be possible without many of the great teams I work with at many institutions, Scooped when I was at UNC, our DCOR Center at Duke, and of course all the amazing other institutions involved in Greenlight. I would like to acknowledge our funding from the NIH, NERSA, the Robert Wood Johnson Foundation, the Academic Pediatrics Association, and now of course PCOR. I want to give special thank yous to my research coordinators. You can tell we lean on them heavily, and I couldn't do this work nor give this presentation, as you saw, without especially Carla Mena, Jenna Howard, Javier Rodriguez, and Sophie Ravenbach, and many other colleagues who have helped me think with a health equity lens, including the PI who's listed there, Corey Flower, but many others who have contributed to the work presented here, Michelle White, Charles Wood, Melissa Kay, Colin Orr, Naomi Duke, Rashina Chalera, and all the stakeholders and participants who informed Greenlight and made our work and findings more equitable, important, and impactful. You can see Greenlight has a huge cast of characters across now 6 sites, and we're really proud of the many folks careers we've been able to foster, but also people we have learned from every step along the way. And at this point, I think there's a couple of minutes for questions, or feel free to contact me in these ways. Thank you so much again for hosting this important conference.
We have 2 minutes for questions.
Dr. Perrin, the first question is, how long were primary care visits, or more specifically, were primary care visits any longer than usual?
That's a great question. Thank you so much for that one. So primary care pediatricians have a lot to counsel about with anticipatory well child care. And one of the many things they're counseling about is feeding. In fact, many, many parents' questions are around feeding. So in terms of the Greenlight intervention, we found it really didn't add very much time when we looked at it. And in some cases actually made that more streamlined. I think the injury prevention side was a little bit more questionable, because while we do injury prevention, we don't usually focus on it quite as much as we did for that arm of the study. But we felt it was important to add content in both directions.
Thank you. And the second is, with the incomes mentioned being often below the poverty line, did any aspects in the clinic setting connect families with existing nutritional services like WIC or SNAP?
I'm so sorry, my internet went out a little bit. I'm sorry, can you repeat that?
Yeah, no problem, sorry. With the incomes mentioned being often below the poverty line, did any aspects in the clinic setting connect families with existing nutritional services?
Thank you. Yes, they certainly did. I didn't probably present this data, but about 85 to 90% of our families were enrolled in WIC and many in SNAP. And yes, our study did make those connections. We are also, with the PCOR study, really fostering connections with lactation services. And then many of our clinics have Healthy Steps and other referral agencies. And we also have parameters set up such that if families report postpartum depression, they're connected with different resources. So yes, these are clinics, unfortunately, well adapted to poverty, and already had many things going on, and the Greenlight study has tried to do more to even connect folks.
Thank you. And then for the interest of time, for the other questions, you can contact Dr. Perrin to Twitter or her email. Thank you.
Thank you so much, everybody.
We will store the questions, and we will email Dr. Perrin to follow up after the conference. So please hold a couple of weeks so we can send answers to everyone. Thank you.
Thank you.
And now we call to the microphone to Mrs. Nancy Modelo.
Thank you so much, Dr. Perrin. We appreciate your insights on your Greenlight study, and we appreciate your candor in talking about some of the challenges that you experienced as a result And thank you very much for just your openness and sharing with us. And also thank you very much to Carla for sharing her piece of the story. And best of luck with you on your PCOR study, your new study around COVID. And now I'd like to introduce Dr. Lisa DeCamp and Dr. Sarah Polk. Dr. DeCamp is an associate professor at the University of Colorado. And they'll now spend a few moments talking about their study engaging immigrant Latino families and community stakeholders to reduce disparities in childhood obesity, which is the project that is the driver for today's conference. So thank you.
Thank you, Nancy. I am going to share my screen and we'll get started with our portion. So again, as Nancy mentioned, my name is Lisa DeCamp, and I am at the University of Colorado. I was at Johns Hopkins until about a year and a half ago and part of Centro SOL, and have been fortunate enough to continue some of my work with Centro SOL and with the great team that we have there, and it has certainly been a joy to do so. Our project really dovetails nicely with what Eliana talked about with Greenlight. And I was actually a resident at UNC in the very, very early stages. We saw like the very early prototypes, so it's always fun for me to see what they have done after that and to reconnect with Eliana, who has provided mentorship for me throughout my career. So you can see we kind of all come full circle. So as Nancy mentioned, there is a funded project by PCOR that is the driver for the work that we've been doing at Centro SOL related to childhood obesity over the last few years. And Centro SOL has really been focused on obesity since the beginning, but this project has allowed us to connect with the community in a different way to really think about action steps to address the childhood obesity disparities that Dr. Perrin so eloquently described in her presentation. So this award was a 2-year project to engage a multi-sector stakeholder network in Baltimore to develop action steps to think about childhood obesity disparities. And the focus of this project, while we believe prevention is extremely important and a key piece of what needs to be done to address disparities, there are so many children who are already overweight and obese that we do need to think about how we provide support to those children and families who are already overweight and obese to move towards achieving a healthy weight. And as was mentioned, this is a project funded by PCOR, the Patient-Centered Outcomes Research Institute. And this is a Eugene Washington Engagement Award. And today we're presenting really the culmination of that project, which is our action plan. And so what we told PCOR is we would engage this multi-sector stakeholder network and come up with some action steps. And so we're going to provide an overview of the action plan today, and then there will be some opportunities to for you to provide additional feedback so that we can finalize this and distribute it to our many community partners and other influencers in the community that may be able to help us take these action steps that we've outlined. As I mentioned, we had a stakeholder action network, and this network was composed of 4 subcommittees in the steering committee. Our patient engagement subcommittee included members of our Latino Family Advisory Board that is part of Centro SOL and Johns Hopkins Baby Medical Center. This included also our some youth advisory board members. We had a community engagement subcommittee, and this is a network of community organizations focused on the health of the Latinx community in and around Baltimore. This subcommittee was led by Comité Latino, which is a grassroots community organization focused on the many aspects of health, well-being, safety, and inclusion of the Latino community here in Baltimore. We had a healthcare delivery subcommittee because we really wanted to understand how to relate these efforts at treating childhood obesity to healthcare delivery and financing. And so those members included a managed care representative from Medicaid, endocrinologists, obesity experts, and other leaders in healthcare delivery. Our research subcommittee was really the Centro SOL investigators and staff. And these subcommittees met individually, and then representatives from these subcommittees came together in the steering committee, which is at the center here. So we did a lot of meetings. At the beginning, they were all in person and they were super fun. And then in the last part, it has been virtual, and that was a pivot that was a little challenging, but we were very thankful to have established rapport and relationships prior to this. And we are thankful for all of the commitment of our stakeholder network members to the many meetings that we had to accomplish this work. And so what did we do within the stakeholder network to really think about how to take action related to the treatment of childhood obesity for Latino children and immigrant families? At the outset, we defined some essential questions, which I'll talk about later, to help us define the meeting goals for each subcommittee. During subcommittee meetings, we used user-centered design activities to answer these essential questions related to obesity treatment. Our research staff then used the meeting notes to generate summaries, and then the steering committee used the summaries to develop result synthesis and then the recommended actions that we present in our action plan. We shared our draft products throughout with subcommittees for feedback and corrections, and then we now have a draft action plan that reflects subcommittee feedback, and then we need to enter into our final step, which is feedback from all of you and final feedback from our subcommittee members. So our essential questions that guided the work and the meeting goals for our subcommittees were the following. So the first essential question was, what are the key components of a community-based obesity treatment program for Latino children in LEP, so limited English proficient immigrant families? So this is a population very similar to that we're targeting, that is involved in the Greenlight study. Our second essential question was, who should be involved in the delivery of and as participants in this obesity treatment program? The third, what are the existing community and healthcare assets for promoting healthy weight among children and Latino immigrant families? And then what are the current community and healthcare barriers? So this is how we organized our work, and this provided us with a rich discussion during our meetings that really helped us to come up with the action plan. One other thing, really one of the most fun parts of this project was the use of an additional engagement method, Photovoice, to address essential questions 3 and 4 with our patient engagement subcommittee. So Photovoice, if you're not familiar, is a research method in which community members take photos, engage in group discussion about the significance of their photos. The purpose is really to answer a question about how to address a problem or challenge in their community that is negatively affecting the health and safety. Here on the right, you will see really the Photovoice process. So we asked questions, we sent Photovoice participants home to take photos, they reconvened to discuss their photos, choose the ones that best represented the themes that they identified. We compiled this into a photo book, and some of you attended the exhibition and where we introduced the photo book and the photos. This Photovoice exhibition was a great opportunity for us to bring subcommittee members together in one space, as well as other community organization and political and policy leaders to understand this work better. So we were very happy to receive supplemental funding from the Bloomberg American Health Initiative to incorporate this engagement method into our work. So at this point, I'm going to hand the presentation off to Sarah Polk, who will discuss our findings to give some context for the recommended action steps that we have at the end.
The photo you'll see here is from a subcommittee meeting hosted in the community last spring, and we're very grateful to everyone who was willing to participate in a subcommittee. And so these are some of the answers to the essential questions, and we'll present the findings from the various subcommittees. So essential question 1, what are the key components of a community-based obesity treatment program for Latino children and LEP immigrant families? The community engagement subcommittee had comments on content, sustainability, duration, and setting. These were all important sub-themes. and the community engagement committee particularly focused on the importance of parent education, that there might be limited knowledge in some instances. And for sustainability, highlighted the importance of offering equal opportunities in light of existing economic and structural disadvantages. I won't read all of the content, but you'll just see that there was over time some variation in the responses depending on the subcommittee, and really reflecting both the experience of subcommittee members, perhaps their professional vantage point, and it was really important to have the various voices represented in the work. And so essential question two is who should be involved in the delivery of and as participants in the obesity treatment program. And again, we had different responses and complementary responses coming from the various community engagement subcommittees. And this is a time to point out that while the lived experiences of the community engagement subcommittee members and the patient subcommittee members overlap substantially, it was important to us to have them be somewhat distinct because due to lack of healthcare access, the community engagement subcommittee members might not have experience with the healthcare setting, and so have a slightly different view of things than families who do have healthcare access, often only for their children, and those parents would be represented on the patient engagement subcommittee. So I'm not going to go into the details, because you will see in our findings will represent sort of the synthesis of the voice of these participants. And then 3, again, what are the existing assets for promoting healthy weight? And then finally, essential question 4 was sort of the counterbalance, was what are current community and healthcare barriers for promoting healthy weight? And so next we'll sort of present some findings where we brought together these various voices, which were very rarely at odds, but just sort of provided a fuller picture of what was needed, both and incorporated some issues related to feasibility. So these are some recommended actions, and the recommended actions fall into 2 goals. And goal number 1 is to deliver an obesity treatment program for Latino children and immigrant families, which will be focused on knowledge relevant to healthy weight and the skills needed to make behavior change and to overcome obstacles and challenges encountered at home as well as in the community. And sort of detail that a little bit further. So what were all of our participants telling us about treatment program characteristics? And so these are sort of the most important characteristics, that the program be flexible, that it explicitly focus on engaging multiple adult family members, that it acknowledges family or community level barriers to healthy, that it acknowledges family and community level barriers to healthy behaviors, such as working parents with multiple jobs and limited free time, and that it acknowledges community level barriers, such as unsafe neighborhoods. And then regarding content of the program, there were 3 components: education, group physical activity, and cost-conscious healthy snack preparation. So these are what each session would be composed of, and that these 3 activities within the program would take place during educational workshops in the afternoons, evenings, or weekends, reflecting competing barriers faced by parents, and that these sessions or workshops would be divided into 2 program phases. So phase one, weekly educational workshops and individual support. So those two things happening at the same meetings for 3 to 5 months. And then a phase two, which can be considered somewhat of a maintenance phase, comprised of intermittent support for an additional 4 to 6 months. And I should comment that the individual support can take the form of brief consultations for families when they're in person, post-COVID, in person with the program, people delivering the program, and also take the form of follow-up text messages or calls from program staff to families. Treatment program location, it was the preference for community-based organization was very clear, and characteristics of that organization to include a place already known to the Latino immigrant community, accessible via public transportation, and with adequate space for group meetings, exercise, and snack preparation. And then who will participate in this program? So on the children, the index children, so overweight and obese children referred by their primary care provider, and that siblings of referred children or the index children need to be welcome to join. And that at least one parent or caregiver needs to attend with each child participant, and that additional parents and caregivers are also welcome, and that there needs to be special efforts to include fathers. And then to deliver the program, this was a very interesting conversation. So the two program facilitators delivering the program would be a nurse and a community health worker. Regarding the nurse, the presence of a health professional is valued by community members, and physician cost is prohibitively high. That was clear according to the Healthcare Delivery Subcommittee. Regarding the community health worker, they have a critical role in keeping families engaged in the program over time. Community health workers are valued by our community members and recognized to be an important team member in other community health promotion programs, both with which we're involved as well as in previously published literature. And community health workers do have a recognized role in cost-effective and culturally tailored healthcare delivery. And then if you can offer the program, how do you sustain it over time? In the short term, this probably will require grants, but in the long term, if it proves to be effective, it will need to be sustained through health insurance coverage. And the community-based diabetes prevention program, which is a program for adults, could be used as a model. And I will turn back to Lisa.
Lisa, you're muted.
Great, thank you. Sorry, I had hidden the video and I couldn't find myself. Let me get back to the correct slide. Great, all right. So Sarah was talking about the first aspect of the goals from our action plan, and really related to the obesity treatment program that we were seeking to co-design with our stakeholders. The second goal that came out of this really is to collaborate with community members and Latino serving organizations to advocate for policy solutions necessary to overcome community level barriers to Latino child healthy weight. And what we found through our stakeholder network is our community engagement and our patient engagement subcommittee were well aware of the links between structural and social determinants of health and weight. I think we think of this as something that we, as a healthcare community or as a social services or welfare community, are have sort of this special knowledge of this link and are bringing services to our clients or patients to support their addressing their social determinants of health needs or addressing some structural barriers to the extent we are able. But our community members know this well, and they really encouraged us to think about a clear linkage between an obesity treatment program and others and solutions to structural barriers. The things that we discussed in context of this program were that they needed places in the community to facilitate physical activity and changes in the community to facilitate this. We talked a lot about providing safe, convenient places for exercise, and we talked a lot about school programs that could be used to be complementary, such as enhancing school recess. Things like having monitors to encourage active play, making sure that recess time is protected, and that recess could not be taken away as punishment for bad behavior. Other pieces, as far as structural goals related to this, were facilitation of healthy eating. We talked similarly to school recess, thinking about school lunch policy and the quality of the nutrition of the school lunches available, and thinking about programs that have demonstrated some success in increasing school lunch policies, such as those that increase access to fresh and local foods. And then was just so struck by the photo that Dr. Perrin had from the corner store. I haven't seen that one, but we do know that the tiendas or other, even grocery stores, the way food marketing is employed is really to bombard low income and communities of color with advertisements related to unhealthy foods and nutrition, sort of calorie dense, nutrition poor foods, and to place those foods in spaces in stores that are easy to access. One of our Photovoice pictures was of kind of the entry to a store, and it was entirely clear from that picture that all of the unhealthy food was right at the front, and you could not see the healthier food. We didn't, in our action steps, specifically address the other barriers that did come up that are related in this setting of structural racism and marginalization. And I do think that was one area that was discussed. We tended to focus in on the obesity piece and thinking about those policies, but I do want to acknowledge that context is critical, the critical piece of addressing the obesity disparities that we see among Latino immigrant families. So that was a whirlwind tour through our 2-year project and through our action plan. And all of you will be receiving a PDF of the draft of the action plan. If you have any first impression feedback today, we are happy to receive it in the few minutes that we have for questions. We will also have some follow-up feedback meetings that you can attend, and we are hopeful that some of you will attend in response to the PDF copy of our draft action plan that we will be distributing. We will have 2 meetings, one in English on November 4th, from 10:30 to 11:30 a.m. Eastern. I may be the only mountain time person here. It's a little early, but just to, depending on where you are, and just so you know that that's Eastern time. The second meeting is in Spanish, and that is on November 11th from 11 a.m. to 12 p.m. Eastern. The action plan will be available in both English and Spanish and accessible to our community members regardless of their English versus Spanish language preference. If you cannot attend one of these meetings, but you do have some feedback to give us, please email us at centrosol@jhmi.edu, and we will incorporate that into our finalization of the action plan. And then we will get our final action plan to everyone. We're hoping sometime by the end of November. So I will stop there. And if there are any thoughts, questions, before we go to our break, we're happy to address those.
We just posted the RSVP links for the feedback sessions in the chat. You can click the doodle poll and RSVP for either the English or the Spanish session. And if you have any questions for Dr. DeCamp or Dr. Polk, you can also share them in the chat now. We have 5 minutes left for this presentation.
So Angelia, I'm seeing a question about how you're involving more participation from fathers. So she said, we mentioned specific efforts to include fathers. And that has been a struggle across many obesity interventions. And it may be also a question for Eliana if they have any data from Greenlight. But we have piloted an evidence-based obesity treatment program in the clinic setting. And there was some father participation. It does take a particularly welcoming environment and thinking about the timing of when people can come and thinking about overcoming potentially some cultural barriers to sharing the load in child rearing and food preparation and all of that. And so as we enter into the next steps of work, we didn't have much father participation, or really any father participation in our stakeholder network, and we think of that as a limitation. We had some fathers that initially participated in Photovoice, but couldn't continue because of work schedule changes. And so their voice is missing. And while some other studies have done some work to think about how to involve them more, the logistics have been complicated. And one of the pieces of the flexibility part is really encouraging fathers, if they can't come to the first one, but they come to the second meeting, whenever they can come, they're welcome. And we will need to do more work with fathers, thinking about how we can make the environment as welcoming as possible.
Yeah, I'll just add from Greenlight's perspective, 94% of our participants who when we had them enroll, they were supposed to be the people who would be the most likely to bring their child to well child care. 94% were moms, and of that 6%, actually a decent percent were grandmas and not fathers. So really a small number of our participants. We did try to make our materials very sort of showing of ways fathers can be involved in a lot of the behaviors that we were trying to promote. But in terms of participants in Greenlight and as frequent bringers of their children to early well child care, not so much.
Okay, so I see this chat from Brian about One More, One Less is a mentoring youth after school program in Curtis Bay and Pimlico, doing urban farming, healthy culinary demonstrations, and youth cooking. They have not had success integrating the Latinx population, but this is what our conference is for. And so Brian, I'm sure Monica will be reaching out because she is the best person to start those conversations. She's really good at seeing where we can bridge those divides. And then I'll advertise our breakout sessions is because one of the things is we've discussed how obesity is a particular disparity among low-income and communities of color. And so really understanding how we can find solutions that are both, there's this tension between tailoring to particular needs and creating solutions that are open and inclusive and welcoming to all. And so we'd love to talk with you and love to learn more about your program.
Thank you, Dr. Polk and Dr. DeCamp for this presentation. I would like to share with everybody what's coming next in our agenda. We have a short break, 10-minute break until 10:40. For those of you who chose to be in panel A, please stay in this Zoom link For those who chose to be in panel B, which is schools as resources, Whitney sent you the link, the Zoom link for that panel. You can jump onto that panel during the break and be there by 10:40 a.m. You have to wait until Whitney opens up that Zoom link. The reason we have two separate links is because we are recording the entire conference and we want to keep the archives for us and to share with all of you. During the break, you can go to your social media and share the Latino Health Conference, LHC 2020, and tag the Urban Health Institute and the Center for Health Equity and Centro SOL. You can also see some of the work that Lauren has been doing during the note-taking for the first part of the session. And again, for those of you who RSVP or chose panel A, you can stay in the Zoom link. And for those who chose panel B, you will receive a message or you can check your emails with the Zoom link for that session. We are taking a break now until 10:40.
And I just want to mention for some of you who are calling in, we weren't able to assign you a panel. So I'm going to put it in the chat if you want to go to panel B, if you're calling in. Or actually.
Okay, I'll start again. I'm proud to introduce Dr. Rachel Thornton, who will be the moderator for panel A, which is the Coalition Building and Partnerships for Community Progress. Dr. Thornton is associate professor at Johns Hopkins School of Medicine, and she is also the associate director for policy at the Center for Health Equity and a associate director at the Urban Health Institute. So welcome everyone, and take it over, Dr. Thornton.
Thanks so much, Nancy. I'm really excited to moderate this. I wish I was trying to figure out how to get a virtual fireplace behind me, because what we had envisioned here was really kind of a fireside chat with some amazing clinicians and researchers. We've got nursing and medicine represented in our panelists. And the one thing I was going to ask was if we can make sure that Dr. Hernandez is able to turn on her video. So I don't want to belabor introductions. And we also have Florida and Baltimore in the house here. So this is going to be really exciting across all of Hopkins Medicine. And so I don't want to belabor introductions. I just am basically going to give a one-liner for each of our panelists and then go into some Q&A. I have a few questions to get us started. And I'm hoping that it'll be a conversation between them, and we'll leave time as well for audience questions. So first, I'm excited to introduce Dr. Carmen Alvarez, who is an assistant professor in the School of Nursing. whose research is focused on development and implementation of health promotion and risk reduction interventions for underserved ethnic minority women with a history of trauma. And Dr. Nakia Showell, who's assistant professor in the Department of Pediatrics in the School of Medicine, who is also focused in her research on childhood obesity prevention and addressing obesity disparities for racial ethnic minority populations. And Dr. Raquel Hernandez, who is also an assistant professor of pediatrics in the School of Medicine. And she is also the director of the Johns Hopkins All Children's Healthy Weight Initiative. And so what I would love to do to start us off is to give each of our panelists just a couple of minutes to give an overview of your clinical research background, and particularly the areas that focus on childhood obesity prevention. And I think the other thing that, we're going to get into a little bit more, but I just want to start us out with, we're really fortunate that Dr. Alvarez and Dr. Showell are partnering across the sort of age continuum and across the family here in Baltimore. So I'd love, and they are both also core faculty in the Hopkins Center for Health Equity. So similar to me, they're bridging the divides between these centers and really pushing towards community. So I'd love to have the two of them start, and then have Dr. Hernandez talk to us about the amazing work she's leading at All Children's.
Sure, I can start. Good morning, everyone. And thank you, Dr. Thornton, for that wonderful introduction. And it's a pleasure to be here with some amazing colleagues, Dr. Alvarez and Dr. Hernandez, and speaking with everyone today. We're definitely hoping for an interactive dialogue. As Dr. Thornton mentioned, I am a core faculty member of the Center for Health Equity, and I'm a general pediatrician by background, and a primary care provider at both our Harriet Clinic and Children's Medical Practice, which are our Hopkins affiliated primary care clinics for children and families. My area of clinical and research interests has centered on obesity prevention broadly, but with a specific lens for early childhood obesity, so children under the age of 5, and also focusing mostly on families who are at highest risk for obesity and cardiovascular disease. So our Black and Latinx population, as well as our low-income children. So much of my work has been centered on looking at what are some of the factors external to individual behaviors that influence behaviors amongst children and families, with a specific focus on neighborhood context, soliciting perspectives from parents of families, parents of children who are in the age of 2 to 5, and understanding what are some of their barriers and opportunities for health behaviors given where they live from a residential standpoint. And also more recently thinking about how we can enhance the partnerships or leverage the partnerships between pediatric providers and parents to optimize obesity counseling within practices. So looking at practice-based interventions that can be informed by some of this information. And again, I've always had the hat for collaboration and realizing the importance of collaboration, particularly amongst thought leaders across the lifespan. And so I'm really happy that we're able to leverage these connections. And with Dr. Alvarez, who focuses, I know, only on adults, but how we can synergize our work. And I think it's critically important, is as we know, the health of parents are critically important to that of their children, and the cycle can continue. So I'm happy to speak more today about specific projects, and looking forward to the dialogue.
Great, thank you, Dr. Showell, and good morning to all. So as Dr. Showell alluded to, my program of research focuses on survivors of adverse childhood experiences with symptoms of depression and anxiety, primarily among Latina immigrant women. This is a population that is more likely to suffer from mental health challenges. The population that has experienced ACEs, that is. So my work focuses on identifying points of intervention for this population. So what modifiable factors can we target to improve their well-being? We now know about the phenomena of intergenerational ACEs, where the child maltreatment that parents experience can also impact their children. Parents who experience child maltreatment may engage in behaviors that can negatively impact their child's health. So my work has potential implications for childhood obesity, but deals more directly with adults and working to support psychosocial well-being in adults. Ideally, this will then also support well-being in the entire family.
Hi, everybody. It is such a pleasure to be with everyone and bringing in some Florida sunshine your way here in my office. And I'm thrilled to reconnect with fabulous colleagues like Rachel and Nakia, and also to meet new colleagues with the same passion. So as Rachel indicated, I wear a few hats here at Hopkins All Children's. From a research perspective, my background and interest has focused primarily on early childhood obesity, similar to what Nakia's age window of the preschool age group, and identifying factors that impact minority families in terms of their understanding of their child's weight risk, as well as the role of the practitioner in communicating around risk. More recently, I've been thrilled to join efforts with Dr. Sarah Johnson in continuing our cohort here at All Children's, which is really focusing on the social determinants and epigenetic factors that may influence the development of obesity. And so we've been thrilled to now grow our cohort to over 400 maternal child dyads, where we're following moms actually prenatally and children into the first 5 years of life to really understand the complex factors that influence growth. And so that, I think, is just a quick snapshot of some of the research that I've focused on. From a clinical world, as Rachel shared, I am very fortunate to lead the Healthy Weight Initiative, which includes a multidisciplinary weight management clinic that we have here based in St. Petersburg. And that clinic is connected to a few community programs that we have developed that are age specific. So we have an elementary school community family intervention, as well as a teen program that we've been able to launch. And we've also had some partnership from our school-based, we have some high school school-based health clinics that have worked with us in identifying potential participants for this program. So we're very happy to continue to grow that kind of community footprint, as well as to grow the multidisciplinary clinic that we have here. So I'm thrilled to continue this conversation, and I love the fireside idea, Rachel. It feels cozy already.
Well, thank you for those amazing introductions. You know, and really, because we're here today to talk about community partnership, and all the partnerships that are required to support healthy growth, healthy weight in children, and transition into healthy adulthood. I wanted us to dig in a little bit more and ask all of you to provide us with a few examples from the work that you do on coalition building and partnerships. And I think we could talk about this for, I don't know, the rest of our time together, but just to kind of queue up for us, both internal to your own health system environments and then external, what your approach is and what examples you think from your own work represent how these partnerships can really work well for the research and you know, for achieving the ultimate goal of supporting, you know, healthy weight.
I can start again. That's a great question. Thank you, Rachel, for that. So when I think of coalition building, and particularly thinking about my work with working mostly with parents of young children and community partnerships, I think it's important to define, you know, what are the important communities that you want to forge relationships with, depending on your work, the goals of your work, and your vision. So for me, it was important to get input from parents who were reflective of the population that I was serving or hoping to serve with the research that I was planning. So some of my earlier work, we solicited input from parents of one of our clinic populations, using parents who are serving on our Latino Family Advisory Board, and posited questions to them that we were thinking about including in future research, and getting input, like what in terms of whether these questions were getting at, you know, the points we were trying to get across, what additional input they would have if we were speaking and trying to, you know, really gain a broader perspective of the issues at hand, and what more they thought would be advantageous from a research and but also from a clinical standpoint. So really informing the type of future interviews that we did, and how we were able, and the way we were able to solicit perspectives, the way we were able to get buy-in to even have parents join our research study, was really important before even building that foundation. So early in the phase of research, getting input from that particular target population was really critical. And then, you know, once the research was done, from our standpoint, it was important to get buy-in from, you know, those important stakeholders that we thought the research would be affecting. So not just parents, but also thinking about other stakeholders like pediatricians and medical directors, for example. And now serving as the associate medical director for the Harriet Lane Clinic, I realize how important it is to have feedback, you know, provided to you after things are over, when you're thinking about how you operationalize clinical services, and also how you operationalize research projects. So the same project that we received input from our Latino Family Advisory Board in the beginning of the project, we also obtained feedback from parents at our other clinic, and thinking about how they were interpreting those findings and what would be important from us to convey to the pediatric provider standpoint, and bridging those gaps in terms of communication. That was incredibly important as well. And I think we got some really interesting feedback, and I think not just informative for what we do with that work, but thinking about how we create and how we inform future projects as well.
So some of the work that I initially started doing in Baltimore started with assessing how providers were assessing for and responding to intimate partner violence with their clientele, particularly with the Latina immigrant population that tends to have less access to resources for addressing this issue. I didn't mention at the beginning that I am a family nurse practitioner. Always thinking about how we in the health services sector can better address health disparities and health equity. So given the nature of this work, I started developing relationships with people within different healthcare organizations, primarily community health centers, as this is where the target population tends to seek care. So I was able to meet with some individuals through mutual acquaintances, and other relationships were formed just through cold contact, calling people up, talking to them about who I was and what I was doing, and as Dr. Sholal said, you know, trying to identify a common ground or a common agenda to work towards together. And so, let's see, primarily community health centers, and also a couple health departments were some of my partners in the earlier work that I've done, and have continued to be partners on some of the work that I have shifted towards.
Those are great insights. I was just trying to reflect on some of the things that are sometimes deliberate and sometimes happen organically, sort of as you develop these relationships with those in the community. I think I shared, you know, the inroads that we've been able to make with our community have largely stemmed from our understanding of referrals from community providers that come to us as an institution that is considered sort of specialty care. And we started to see these trends, focusing on primarily teens who were really needing more support. And so I think looking at those trends helped us develop a program that was kind of more targeted versus us telling, the community what program we had. I think we kind of looked and said, okay, there's a need for this, and we developed that. I think that helped us make inroads with our community providers. The other process that's happened, which has been really interesting, is identifying the organizations within our community that are known for, for lack of a better word, minority health. And so we've reached out to them, and in having just very humble conversations and saying, what's hard for you? What are your challenges? One of our partners is known as the Hispanic Services Council. And this wonderful executive director just very candidly shared, Raquel, we're getting all sorts of requests for research, and we always feel like we're used and abused. And I said, tell me about that. And she said, we have the access to this population that is, of interest, and we get all these requests, but it just really feels like we're spending our resources on things that aren't necessarily important to our families. And so one of the things that I guess occurred and was an opportunity is to help her develop a framework of data collection that could be of use to her, but then also help her organize all of these requests that were coming her way. And it was just really fascinating for me to think of, these organizations who are very lean oftentimes and incredibly committed, who are trying to do their best to understand this kind of crazy term of research, but that they themselves need resources. And so that's actually something we were able to partner on in helping them develop a data framework that was helpful for their operations and their general intake, but that could also provide some output in terms of knowing, okay, here's where we are in terms of our volumes for these different programs. So I give that example because it kind of happened overnight. I listened to her say what was hard, and I think that offering that product, for lack of a better word, without an agenda to do research, has formulated this relationship. So that was a neat opportunity for us here.
Thank you so much. I don't know if it's on my end or not, but we were getting a little feedback at the end there, Dr. Hernandez. So I think I see Dr. Alvarez chiming in to expand or expound on some of the themes you brought up. So go.
Yes, I wanted to thank Dr. Hernandez for making that point about partnership or not necessarily offering something in return, but also availing ourselves to be of service to the entities that we're partnering with, because it is supposed to be a partnership and exchange. And I think sometimes because our community partners are that lean and overwhelmed, sometimes opportunities for, I guess, more equitable partnerships in the sense that they're also gleaning as much from us as we may be from them, doesn't always happen. And so I think we need to be very intentional about reminding them that we are also here to not just for research, but also to render any other services that we can to support their organization. So whether it's doing in-services for some of the staff, serving on a board or a committee for their organization, I think is important. I think we do need to be intentional about remaining visible and letting our partners know that we are here for true partnership. And one of the reasons why my work shifted from intimate partner violence more so to adverse childhood experiences and mental health was because with my first piece of work with healthcare providers, actually, we learned that was where there was also a great need. Not to say that intimate partner violence is not a problem, but that was an area which had not been explored much. And where we identify that there is still a lot more support that's needed for mental health services in the community for this population.
Well, I think you all have touched on a lot of this already. You know, that some of the key ingredients to building successful partnerships. But maybe if we can dwell here just for a moment longer on the idea of sustaining them over time and what your thoughts are about how to do that. You know, and I think Dr. Alvarez already got at this a little bit in her comments earlier about the cold call versus leveraging relationships. But the two ends of the spectrum, sustaining partnerships you've developed, or, you know, at square one, how do you even kind of get started in this space?
Dr. Hernandez, go ahead.
Mm-hmm. I'll take a stab if that's okay. Is my audio a little bit better? Okay, great. You know, I think it's such a great generation of like the getting started in the same. One of the strategies I guess I would out there, it's not working.
Yeah, we're losing you again. You're muted now. Give it a try. I think you just reconnected, Dr. Hernandez.
Can you hear me now? Okay. I'll hopefully this will last. So one of the things I would just encourage is reaching out to those within your own, you know, institution who have been doing this work. I think sometimes we kind of restart conversations that have already been going on. So I think just kind of making sure you leverage your ready. And I think the sustainability of these conversations just reflects on circling back to your partners on what the outcomes are. I think that feeling of having them feel used without seeing about it is something I'm very conscious of. So I think I'm very little effort to update them at various phases of these projects and have them be a big part of how we disseminate this information. So so I think sustainability reflects that you're connected kind of throughout all of these different conversations and really bringing some data back to them.
Dr. Hernandez, I'm sending you a message with the call-in information.
Thank you. Sorry about that.
And if I could just piggyback on something really important that you said, and that Dr. Alvarez also started to have conversation about, is how we can leverage existing relationships. So I think one way is finding out, you know, who at your institution is already doing this work and this kind of work well. So I think using examples, for example, our Center for Health Equity and Centro SOL and Urban Health Institute, which already have existing relationships with community partners. Many of the same community partners, if we're talking about East Baltimore, many of the same community partners that we may be interested in partnering with. So some of these conversations have already started to take place, and they may be in different realms of research, but the relationships, there's already a foundation for building those relationships and hopefully being able to sustain those relationships in different areas. And the other perspective that, you know, I have as, and Dr. Alvarez and I were talking about this as well, and thinking about what are some of the success factors for sustained relationships. Not that this is a prerequisite or requirement for research, community engaged research, but it does give you a different perspective when you are a part of the community. So I'll take myself as an example. I live and work in East Baltimore, 10 minutes from the hospital in a similar area, not far walking distance from many of the patients and families I serve. And being at those community meetings where there are members of the communities, you know, voicing their concerns about safety, about opportunities for, you know, what's going to be the impact of this large green space area. How are we going to utilize that for children and families programming? So just having that insight on what are the main concerns of people who actually live in the area where your target population lives. And I think that's been incredibly informative in thinking about moving forward, and being able to build relationships with members of the community and also advocates that we may not have, I may not be familiar with as just being, a faculty member at Hopkins, but we'll become more familiar with by just being within the community and being open to having those conversations. And I think it's incredibly important in terms of sustainability to be very mindful of how we're giving back, and to not have a lopsided relationship with community partners. And I don't think that, I don't think we always do it perfectly well. And I think there's always opportunity for improvement. There's always opportunity to enhance the infrastructures that we have, to enhance those partnerships. And it takes resources. I think, bottom line, I think it takes resources and proper infrastructure and insight to say, as an institution, as a department, as a research team, that, once this research is over, we're not going to leave, the community partners that we've been working with for a year or 2 years high and dry. And thinking about how you can invest or how you can, budget or think about those resources beforehand, and thinking about a sustainability plan, not thinking about a sustainability plan once the research is over. So I think those are really important steps in terms of enhancing success and to have viable relationships with community partners.
Great. Well, I know I want to make sure we leave time. I think at about 11:20, if I'm right, we're going to open up the chat for folks to put in questions. I think this is, I love the fact that you all as a panel encouraged me to think about asking about this, that we talk a lot about our successes. I think Dr. Hernandez gave us a little bit of a signal in her discussion about the one community organization that reached out to her to say, we're feeling overwhelmed by all of this. It is kind of a privilege sometimes when an organization or a partner is willing to disclose or confide that there is a challenge in the relationship. So that's a privileged place to be in terms of responding to challenges. But, if any of you have really, poignant or illustrative examples of unsuccessful partnerships and the lessons you learned from that, I think it's a sign of our humility as researchers when we can talk about those and, and tell us what you've learned, what you've done differently, or what potentially, if it's a partnership you've observed, perhaps not as kind of the lead force behind it, what you gleaned from observing a partnership be unsuccessful in any context and how you've taken that forward.
I can share an experience. This was with my work with trying to learn more about how healthcare organizations were responding to intimate partner violence. And I had one partner offer to meet with me, but in a different format than what I had initially planned for. They were suggesting more of a group interaction or a group meeting, if you will. And because that was just not what I initially had in mind, I reiterated the format that I was looking for. And that definitely closed the door. So I think, when you think about being a true partner, then lesson there, you definitely have to be a lot more open-minded and come to the table definitely with a lot more humility and what's the phrase I'm looking for? Come to the table in the way in which you have been invited. So it may not look the way you initially intended, but if they have opened the door through a particular path, then that is probably how you should proceed to start the relationship if you don't already have one established. I think that's just part of the trust building. So I have since been working very hard to rebuild that relationship, or even initiate that relationship. Yeah.
Dr. Hernandez.
Rachel, I can take a stab if that's okay. Can you all hear me okay now? Okay, sorry about that. I appreciate Carmen sharing that. I think humility is always like a great trait for researchers, right? And I think maybe similarly to what Carmen shared, I think my example reflects potentially too much eagerness on both sides to partner, and realizing that our agendas were maybe different, too far in. So my example is a community insurance agency who was interested in tackling the issue of obesity in teens. And so I connected with them with a concept that was really a pilot of connecting at-risk teens in schools with mobile health sort of approach in terms of Fitbits and tracking devices, and then also providing some motivational interviewing. From my perspective, the value of this project was that this was an at-risk group, and that this could be an ongoing connection in terms of the youth, which the partners saw also as an opportunity. But in their mind, the impact was in volumes, and this was a large school, and that this was, a big opportunity for them to brand, what they were doing from a community perspective. And I also saw that as an opportunity, but in my sort of very eager research mind, I said, we'll get to those numbers at some point, and then, everyone will be happy. And I just didn't realize that they really wanted, more of that footprint in the community to brand versus, the research impact and outcomes of things. And that's something I think I've started to realize more is, and learn from, is that I think I was too eager to get this project launched and make this relationship work, and wasn't transparent enough about how difficult sometimes it is to do research and to get big numbers. And then I've also realized that sometimes you've got to wait and pause and maybe say no thank you to a project that may not be, kind of where you see yourself going. So that's my lesson learned, is I think just making sure that the opportunity, the agendas are clear, and sometimes saying no if, in terms of the funding.
That is such an important point. I mean, as someone who straddles practice, policy, and research, the rapidity of decision making and coming to conclusions, and the comfort level with identifying successes or failures is so different, and I think it does put a lot of pressure sometimes on the research process, which is intentionally a very deliberate and as much as possible standardized process. And so that is a really important one, I think, to lift up. Thank you for that. Dr. Shoal, did you want to add anything on this topic before we kind of move over to concluding comments? I also see some real gratitude in the chat from Rihanna Platt on the openness of sharing challenges and failures. I think this is part and parcel of being community engaged in our work. So I would expect nothing less, but it's nice to see acknowledgement of that.
The only thing I wanted to add is just echo a lot of the lessons learned that Dr. Hernandez and Dr. Alvarez already mentioned, and also I think I look at this as more of an opportunity for improvement. I kind of alluded to this a little bit earlier, but just ensuring that there is an existing infrastructure to provide a space for bidirectional communication at all phases of research. And again, I don't think that I can speak for myself, I do that perfectly well, and not that I have control over that in all situations, but from my experiences and what I've observed, having great infrastructure for advisory boards that includes critical members of the team, critical members of the community, and includes representatives that in some venues may not always have a voice and may feel voiceless, but providing an opportunity for communication and voices on those particular advisory boards as representative of the community that you want to serve. And I think that is a critical part of research, and it has to be a space at all phases of research, not just before when we're trying to design, not just during, but after, and even after that. And if we're talking about sustainability, I think, forming advisory boards around specific projects is great, but having advisory boards that exist for years and years and years, which a lot of our affiliated centers have great examples of, that is very critical.
Great, thanks to everyone. Well, let's get to some concluding comments from each of you. Anything that the discussion has brought up that you would like to touch on further, or even, a challenge to our colleagues in the audience who are interested in learning more, and I assume many of them are already engaged in community engaged research. I think the other thing we didn't talk about that much here, but I think is sort of infused into the way you all do your work, is working across communities that are commonly marginalized but may not feel connected to one another. So if there are any thoughts specifically on that topic, I'm looking at all of you really, but I know specifically Dr. Showell is working across African-American communities and Latinx communities around children's health. And I know Dr. Alvarez also, in her affiliation with the Center for Health Equity, has been, collaborating with the center on some of the work that affects, chronic disease management in the broader, population of racial ethnic minorities who are experiencing disparities. So in any concluding comments, I don't want to direct us any specific way, but those are just some of the things that have arisen for me in listening to our conversation. And I will, I'll wave my hand if I see additional comments coming into the chat that we want to leave a few minutes to discuss.
Dr. Thornton, there is a private comment that I can read.
Great.
Given racism and racial equity, when researchers work with community, how do we bring in social justice in the research, and also who owns the data?
I think the question about who owns the data is complicated. I don't know that I might defer to my colleagues to answer that question. I mean, I have an answer in mind, but I don't think it's a very community-centric response. But in terms of addressing issues of social justice, I think that gets to the importance of why we need a diverse representation on our community boards, or diverse perspectives in the work that we're doing. So I think the more that we have community input at different levels, the more we can address issues of social justice. And maybe it's small S's and small J's, hopefully, taking us bit by bit to making larger change. But yeah, I think the more that we can have interdisciplinary input and perspectives from different members in our community, the more we can address the issues that are of most importance to the community.
And I would, oh, go ahead.
I would agree with, but I'm sorry, Nakia. I wanted to just underline that the representation piece, I think, is so critical, but also very difficult to do. And I think that the social justice piece is something that we are all struggling to do well and to identify sort of best practices, that, and particularly around data. I was just going to comment that one of the lessons I've had is in having conversations around what data is really sort of vulnerable data, or let's call it sort of, high impact data, and then also understanding how the data are collected throughout the organizations that potentially you want to partner with. So that we throw the term data around quite a bit, but I've learned that not everybody defines or considers data the same thing. And so I think having transparency around what you as a researcher are interested in, and having conversations around what you intend to do with the data, I think, we think that we make those things clear, but I have learned that, gosh, even in very deliberate conversations, it's still a challenge. I've also learned that to make research work that is truly community-based research, there are some very operational things that need to be in place, including things like, and I don't know if this is helpful, but affiliation agreements, just kind of saying that you as an entity and that group as an entity are agreeing to a partnership longer term, I think helps everyone understand that this is not dating, for example, that this may be more of a marriage, and that there will be iterations of projects and data that will need to be revisited. So I think I've learned that kind of that formal legal piece of partnership can help conversations of social justice, in the sense that there is more transparency around intent to partnership longer term versus that kind of one and done experience, which may have been the past approach. And I think we're learning that formalizing these relationships may be a benefit to both groups. So those are just some of my thoughts.
And I agree totally with what Dr. Hernandez has said. And the only other thought that comes to mind, we talked about diversity of thought and representation on the community side, but also I think this is why it's even more important to have diversity of thought from the research side, right, and the planning side, and leveraging the expertise from our other colleagues, those who have experience more in the health policy and social justice realms. I think we tend to operate in silos, some of us, and having a non-siloed approach, particularly when it comes to how we best represent ourselves to the community, and how we best partner with the communities is very, very essential. And particularly when it comes to issues of social justice. That was a great question. I definitely had to think a little bit more about, and it's going to be incredibly important, particularly during this current environment.
Well, we've come to the end of our time together, I believe. I want to respect that there's a jam-packed concluding session. I'm sitting here fiddling, trying to find my reactions, and I want to give just a rousing standing ovation round of applause to these amazing panelists for the work they're doing, for their commitment, and for their willingness to kind of share, the good, bad, and the challenging in all of that work. So please join me in a virtual round of applause for our panel.
Thanks.
Bravo. Thank you very much. Thank you very much for joining us. Thank you, Dr. Thornton, for guiding us in this amazing conversation. I wish I had more hands to tweet everything you said. Thank you very much. We are almost at the end of our morning, and we're going to jump onto our closing session For everyone joining the call, please make sure that you have your cameras off and your microphone muted. I wanted to share a couple of reminders before, while we wait for people to join. There is going to be a feedback session coming up in November for everyone to have a chance to review and give comments, make comments about our action plan and the recommendations that Dr. Polk and Dr. DeCamp were presenting this morning. So I'm gonna, in the comments, you're gonna see a comment from me with the links to RSVP for those meetings. The meeting in English will be on November 4th at 10:30 a.m. and the meeting in Spanish will be on November 11th at 11 a.m. And I'm going to switch to Spanish because we have some community members who just joined the conversation. Vamos a tener una sesión para revisar el plan de acción con las recomendaciones acerca de cómo hacer frente a la obesidad infantil y sobre todo al tratamiento y prevención de la obesidad infantil. Las sesiones van a ser el 4 de noviembre a las 10:30 de la mañana en inglés y el 11 de noviembre a las 11 de la mañana en español para que todos tengan oportunidad de leer el plan de acción y de hacer comentarios y recomendaciones. I just posted the feedback, the RSVP links for the feedback sessions in the chat. Acabo de poner los enlaces para confirmar la asistencia a las sesiones de comentarios de nuestro plan de acción en el chat. And without further ado, I would like to introduce our panelists, our guests, special guests today. Voy a presentar a nuestras invitadas especiales ahora. Por favor, enciendan sus cámaras cuando diga su nombre. De el Comité Latino de Baltimore tenemos a Lucía Islas, que es la presidenta, y Rocío Herrera. From Comité Latino de Baltimore, which is a neighborhood association in Southeast Baltimore, we have Lucía Islas and Rocío Herrera. Centro SOL started a community advisory board, a Latino family advisory board several years ago with the leadership of Dr. DeCamp and Dr. Polk, the Children's Medical Practice. And we have two of the members who participated in our project. Hace varios años, la doctora DeCamp y la doctora Polk empezaron un consejo de familias latinas y tenemos a dos miembros del comité, del consejo, que participaron en el proyecto, Claudia Ruiz y Paola Hidalgo. And last but not least, the conversation with the participants in our study, especially for the Photovoice and the community engagement, was facilitated by Marcena Maxim. Tuvimos la colaboración de Marcena Maxim para la facilitación del proyecto de Photovoice y la integración de la comunidad. This session is going to be in English and Spanish, and I will be interpreting as much as I can for the special guests who prefer to speak in Spanish. Esta sesión va a ser en inglés y en español y voy a intentar interpretar lo mejor posible para aquellos de ustedes que prefieran hablar en español. Les agradecería, por favor, si prefieren hablar en español, que hagan frases cortas y que su intervención sea corta. Tenemos 20 minutos, 15-20 minutos para esta presentación. So we're going to start asking our special guests what they think about participating in this project. What was easy and what was a challenge? Por favor, ¿podrían comentarnos cuáles fueron las dificultades y los facilitadores para participar en el proyecto? Rocío?
Hola, buenas tardes a todos.
Hello, everyone.
Bueno, yo participé por 2 años en este proyecto, invitada por el Comité Latino.
I participated in this project for 2 years and I was part of Comité Latino.
Fue mi primera vez en este tipo de proyectos y de estudios.
It was my first time in this type of projects and studies.
Me gustó mucho participar porque creo que nos dieron un valor de dar a conocer nuestras ideas y de entender bien este estudio y este proyecto.
It was great to participate because we had the opportunity to understand and share our ideas and understand better the goals of this project.
Ya que es una problemática grande en nuestra comunidad.
Because this is a big problem in our community.
Nos topamos con más desventajas que ventajas.
We found more challenges, disadvantages, and advantages.
Una de ellas en las que discutimos y hablamos mucho fue el idioma. Los recursos no están tan al alcance en nuestro idioma, que es el español.
We talked a lot about language and how it makes access to resources very difficult for us.
Y que los programas que están establecidos están más requeridos para personas que son legales.
And the programs that are available are usually more friendly for people who have immigration status.
Y eso hace una gran diferencia en la problemática de obesidad cuando no están distribuidos bien los recursos.
And that makes a huge difference when it comes to obesity because the resources are not well distributed in the community.
También yo entendí más particularmente de decir que estábamos participando en un estudio no para encontrar soluciones, sino abundar en la problemática.
And something that I understood is that we were participating to understand the problem more than finding the solutions.
También me enriquecí de aprender tantas cosas a nivel de nutrición con partes del subcomité dando sus testimonios y yo aprendiendo de ellos también para hacer un poco la vida más sana.
It was empowering to participate and understand more about healthy habits in this project and learn about how to have a healthy lifestyle with the members of the subcommittee. And Rocío, si te parece, podemos pasar a otra compañera antes de pasar a la siguiente pregunta.
Claro que sí. Gracias.
Gracias. So we're gonna change gears to Paola.
Hola, yo soy Paola Hidalgo, soy del Estado de México. A mí me gustó participar en el proyecto, no solo porque los latinos somos con el más índice de balance de obesidad en los niños, sino porque están escuchando la voz de los propios que están en el proceso de los niños con obesidad. Entonces, es un proyecto que a mi parecer están escuchando nuestra voz, no solo están viendo nuestro problema. Entonces, Perdón.
Paola. I like participating in this project not only because childhood obesity is a big problem in our community, but also because we had the opportunity to be heard and speak up, and that is something that was important for them.
Sí. Y la verdad que a veces el problema viene por cultura, por tradición, y me gustó mucho participar y dar una opinión sobre nuestros niños con obesidad y buscar una solución, no nada más quedarnos sin escucharnos.
And sometimes the problem comes because of culture, and it was good to be able to talk about a solution and to be heard. Gracias, Paula. Doña Lucía, ¿quiere opinar?
Yo creo que nuestras compañeras ya dijeron los barreras y facilitadores. Nosotros podríamos pasar a la siguiente pregunta, Mónica, si usted gusta, o Claudia
Bien.
puede comentar algo.
Claudia, ¿usted tiene alguna opinión sobre qué facilitó o qué hizo difícil la participación en este proyecto?
Buenos días. Primeramente, mi nombre es Claudia Ruiz. Soy de Honduras. Tengo 15 años viviendo aquí.
I'm from Honduras and I've been in the US for 15 years.
Para mí, uno de los problemas que yo he encontrado y me ha ayudado a reconocer es que de repente uno en la casa puede tener los alimentos más sanos para su familia, pero también las escuelas no nos están ayudando, están contribuyendo a la obesidad.
Something that we were able to discuss is that schools are not helping and are contributing to obesity.
¿Por qué digo esto? Porque lo primerito que uno ve son las maquinitas. De repente los niños no quieren comer en la casa o de repente no, porque ya están acostumbrados a la comida. De repente no podemos decir completamente chatarra, pero a lo más rápido, y sabemos que lo más rápido no proporciona los nutrientes adecuados y están ricos en muchos carbohidratos y azúcares.
And first of all, we see the vending machines, and sometimes the children are not accustomed to eat that, or they get accustomed to eat that too much. And we see how carbohydrates can contribute to obesity.
Eso sería para mí.
That's what she learned. So thank you all for your thoughts about what helps and what can be a barrier for addressing childhood obesity. I would like to hear your thoughts about why it is important, and Rocio and Paola already touched some of that, but why it is important to include the community in research. Me gustaría, por favor, si pueden compartir brevemente por qué es importante incluir a la comunidad en investigación. Y si quieren podemos empezar con Lucía, que aún no ha intervenido.
Buenas tardes. Como usted lo dijo, Mónica, nuestras compañeras ya nos lo dijeron. Solo para enfatizar un poquito más, es importante que nos hayan incluido porque, como dijeron, nosotros tenemos el problema.
It is important to be included because we have the problem.
Y no hay mejor ejemplo que la persona que está sufriendo el problema. Gracias.
And there's no better example than the person who is struggling with the problem. Gracias, Doña Lucía. Anyone else wants to share their thoughts about why it's important to include community in research? ¿Alguien más quiere compartir su opinión sobre por qué es importante incluir a la comunidad en investigación?
Podría decir, perdón.
Sí.
Perdón. Claudia, sí. Ajá.
Sí, yo podría decir que es importante incluir a la comunidad, a nuestra comunidad, o no importa qué comunidad. Es importante incluirla porque ellos son, como dijo la señora Lucía, son el problema. O sea, uno está ahondando desde adentro cuáles son las barreras que ellos pueden tener. Bien puede ser económico, social, educación. Entonces ellos más nos pueden explicar cuál sería su mayor dificultad para de repente combatir o estar con la obesidad algún miembro de la familia. Por eso para mí es importante incluirla.
Include the community is important because they may be facing barriers in financial or economic burdens, and including the community also helps to understand if a family member has obesity. Rocío, gracias, Claudia. Creo que tiene el micrófono apagado. Sí, no lo escuchamos. No. A ver, ahora.
¿Bien?
Ahora, sí.
Ajá. Creo que es importante que nos hayan incluido en este proyecto porque, como ya lo dije, nuestra comunidad es una comunidad de trabajos rudos, ¿no? Pero también somos una comunidad pensante. Somos
It
una
is
comunidad.
important that we were included because, as we said, our community can do hard labor, but we also can think.
Y pues con gusto de dar nuestra opinión en este tipo de investigaciones.
And we are delighted to give our opinion in this type of studies.
Eso es todo.
Gracias. Gracias, chicas. No sé si Paola tiene algo más que añadir o tal vez podríamos pasar a la siguiente pregunta.
La siguiente pregunta, Moni.
Gracias. So this is more like a last wrap-up question because as we heard from our community members, for them it was very important to be part of this project. They felt valued, appreciated, and that their opinions, it was important for them because they felt that their opinions were important for the solution of a problem that is affecting their communities. And Marcena was helping us to facilitate these conversations, and we would like to hear from her why it was important to facilitate and have the support, not just to ask a question to a community member, but really to provide tools for them to be able to speak up. Marcena, you're on mute.
Disculpe. Good morning. Como ya han dicho mucho las compañeras, como incluir los miembros de la comunidad es muy, muy importante. Primero, pensamos que las personas que viven en una situación la conocen muy bien.
Including community members in a project is super important because people who live that experience know how they are living it.
Yeah, and pueden tener ideas e información acerca del tema que no se les ocurrían a las personas que lo están estudiando desde afuera.
Study projects can have way more information about the problem because we have an outsider perspective, whereas they are experiencing those challenges.
También la gente de la comunidad tiene información vital y la habilidad para utilizarla. Son miembros contribuyentes de la comunidad, no solo observadores sin voz o dependientes.
Yeah, community members are active participants in the community. They are not just observants or observers of what's happening there.
Además, durante todo el proceso de la investigación, las personas ganan la capacidad de convertirse en activistas que pueden transformar sus vidas y sus comunidades.
During the entire process of the research, the community participants actually become activists that can make a change in their communities and the problem that they are trying to solve.
Y durante este proyecto de Photovoice se podría ver muy bien que nosotros hicimos una pregunta general sobre las ventajas y barreras locales para obesidad de los niños. Pero los participantes llegaron con más y más preguntas.
During the Photovoice project in this study, we asked them only 2 questions. We asked them for facilitators and barriers to address childhood obesity. However, the participants of Photovoice came up with many more questions.
No sé si puedo hablar ahora sobre el proyecto de Photovoice en sí.
Sí, brevemente sí. Ajá.
¿Sí?
She's going to talk about Photovoice. ¿Puedes hacerlo en inglés y en español?
Sí.
Okay.
Puedo probar.
Sí.
Es que, porque Photovoice usa como la fotografía para documentar y compartir las perspectivas con los otros. y las fotografías capturan las experiencias y las voces de la comunidad y provocan las conversaciones profundas y constructivas. ¿Tú, Moni, o yo?
Puedes hacerlo tú si quieres.
Okay, so Photovoice used the photography to document and share the perspective of the others, and the photographs caption the experience and the voices of the community, and also provoke the conversations, constructive conversations. So, los participantes en el proyecto tomaron las fotografías por su propia cuenta y después presentaron las fotos en el grupo durante varias reuniones. Y cada vez llegaban, cuando digo que llegaban con más preguntas, translating. So, los participants of the project were taking photos by their own and then coming and sharing those photos during the workshops with other participants. And during those workshops, there were many, many reflections, and it was more and more questions and answers. So, and this process was very important. Durante las reuniones, que ustedes tenían como preguntas y también las respuestas para las preguntas, y cada reunión provocaba como más reflexiones que querían compartir, y como cada vez estuvimos como aprendiendo uno de otro. Each time we were learning with each other, like one was learning from another.
Mm-hmm. Well, no, thank you so much. It was definitely a great experience throughout these 2 years. We started by defining what obesity was so that we were all on the same page. And then we went through all the way through finding solutions and really learning collaborative from and with them. Durante estos 2 años ha sido un trabajo colaborativo y hemos intentado primero definir lo que es obesidad, ¿se acuerdan? Cuando todavía no teníamos bien claro qué era obesidad, y luego pasamos a encontrar las soluciones a través de las preguntas esenciales. Han sido 2 años de colaboración en la que creo que hemos aprendido nosotros mucho más de ustedes, y esperamos que el proyecto les haya servido también y que podamos seguir colaborando. We hope to continue our collaboration with the members in our community to address the problems around childhood obesity. So, ¿tienen algún comentario final que hacer muy breve? Lucía, ¿sí?
Enfatizando un poquito con lo que usted habló de obesidad, efectivamente, nosotros como comunidad aprendimos, especialmente yo, Lucía, que la obesidad nosotros la veíamos como es alguien que está con demasiado peso, pero nosotros pudimos aprender que la obesidad a veces es genética y es cultural. Nosotros creíamos que nuestra mamá...
Yeah, we learned a lot about obesity per se, particularly me as Lucia. I learned that obesity was not just that someone is obese, but it comes with other things like genetics or culture.
Y aprendimos que nuestras mamás nos decían, coman, coman, coman y no te levantas de la mesa si no comes, pensando que eso era alimentar. Hemos aprendido que alimentar es alimentarse con productos o con cosas que son realmente buenos para nuestro cuerpo. Gracias.
Yeah. Gracias, doña Lucía. Yeah, we learned that when in culture, our moms tell us that we have to eat until we finish. However, we learned that nutrition goes beyond and is like eating nutritious food. So, no quiero robarles más el tiempo. Les agradezco mucho por su colaboración y participación en el proyecto. And I would like to pass the mic to Nancy for the final words with our note taker. Muchas gracias a todas. Vamos a pasar a las últimas palabras de la conferencia. No se vayan, por favor.
Thank you very much. That was really, Monica, that was really an important way to end our meeting by hearing from the voices of the community. And I really appreciated their sharing their honest thoughts about the project and some of the things that they've learned and valued. And one of the things they talked about was the Photovoice and how important pictures and images are to someone. And we really are very fortunate to have Lauren Green, who created this graphic recording, as you can see, this time lapse of her creating this. And this will not replace the slides, which will be available. This doesn't replace the recording of the meeting, but this is really a graphic depiction that we will be able to share with you and on our website, on Centro SOL's website, that will really highlight oops, sorry, Lauren, it's a teeny bit blurry, but it still looks good. This will highlight our conference and will be a record of all of the critical and important things that we've learned today, that people have talked about, various research studies and some of the things that went well, and sharing honestly some of the things that have not gone well. She'll have 2 slides. This is one of them. And again, we'll be sharing it with you and it will remain on the website. And I'm sure Monica and the team will create other ways to utilize this. I was really pleased and happy to be a part of this conference, and on behalf of the Urban Health Institute and the Center for Health Equity, we were really thrilled to partner with you on this really critical issue and conference. Monica or Sarah, I don't know if you want to have any final words.
Thank you, Nancy, and really thank you to everybody for participating. We are ending on time, which always feels like a minor miracle, so we will respect that everybody is given time out of their busy schedules. A very special thanks to Monica, Nancy, and all of the participants of our various stakeholder networks, the voices, some of whose voices you heard today. We would like to hear your voices. So again, you will receive further information about 2 follow-up sessions, one in English and one in Spanish, because we consider this first 2 work sort of the preamble to work that needs to be ongoing, and it will only be successful in coalition. So stay safe. Thank you again. Muchísimas gracias a todos. Que se cuiden. Adiós.
Thank you, everyone.